Afternoon, and thank you for joining us for today's webinar, Breast Cone Beam CT, Emerging Clinical Applications in the Development of Guidelines. Before we begin, I would like to go over a few housekeeping items. Today's webinar will be recorded and available through our website and the RadSite YouTube channel. To minimize noise and distraction, all attendees' microphones have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using your Q&A box. We will do our best to address all questions and comments at the end. I will now turn the presentation over to our moderator, David Georges. Thank you.
Thank you, Andy, and good afternoon, everybody. Thank you for joining. I think we're going to have one presenter that can't make it today for technical difficulty, but we'll be able to make it through the rest of the program without any issue. So without further ado, I'd like to introduce our two panel members, Dr. Heather Richardson, a dedicated breast surgeon, and Dr. Richard Reaven, a fellowship-trained breast imager. Hello, Dr. Reaven and Dr. Richardson.
Hi, how are you?
Doing well, and thank you so much for joining today. Our goal of this webinar is to introduce and explain some of the features and benefits that are provided with a dedicated breast CT device. And I'll ask our two panelists to provide their thoughts on each of the topics. And Andy, if we can have that next slide. Thank you. So let's get started with some of this, the topic matter, and that is there's an interest in cone beam breast CT and it's growing. What do you see as the main factors driving attention to this technology?
Well, I'll start. First of all, David, thanks for having me, and thanks to RadSite for having us on this panel. It's really great to be here, and hopefully we can add some interesting thoughts to the conversation about why this matters now. So as you said, my name is Richard Reaven. I'm a radiologist, fellowship breast imaging trained. I've been in practice for about 15 years altogether. And why this matters now is because as a breast imager, as a radiologist, fellowship trained in breast imaging, I deal with women asking all the time with their regular mammograms, why can't there be a better way? Why do we have to go through this grueling process of a mammogram? Why does the technologist have to squish the breast between two plates? Why is there so much compression? Why is it painful? There must be a better way to come about this. And that's what really led me to do some research many years ago and find about this technology. And what I found is that this technology exists and is ready. And what it is it's a compression-free breast imaging evaluation. And so what this does for patients is it offers women and men the availability of imaging that is compassionate, that's comfortable, and that is, at the end of the day, when it comes to cancer detection, is superior compared to mammography. And so what we're finding is that a lot of women are asking about this. We realize that a lot of women are not currently getting their mammograms. If we look at the national data, what we're seeing is that there's about 80 million women above the age of 40 in the United States. And according to the MQSA, which is the national database which registers all of the mammograms that happen in the country, the highest number that's ever been in 1 year is 39.5 million. And so what we see is that more than half of the women in the United States are not getting a breast imaging examination on a yearly basis. And so they're still experiencing breast cancer, we're just not finding it. And our job as radiologists, specifically trained in breast imaging, is to find and detect breast cancer at its earliest and most treatable stage. And if we can't see it, we can't diagnose it. And so why this topic matters now is because we know that there's a lot of women out there who are not getting their annual mammograms, and we need to find more tools in the toolbox to be able to find these cancers.
Thank you, Dr. Reaven. Dr. Richardson, would you like to add a comment or two about the growing interest in this technology?
Well, patients don't want compression, and a lot of patients are they're post-operative or they have implants, and they want some things fast and they want things that are accurate. And one of patients' biggest complaints are having to come back again and again and again for diagnostic images. So to have upfront information in a true 360 three-dimensional format is very helpful.
Thank you for that. And that brings me to the next question. I'd like to ask each of you to provide our viewers with an overview of the technology starting with what it is, how it works, how different it is from the conventional standard of care, and where you have experienced the most distinctive potential value.
Sure. So what the technology is, basically, it's using the same mammography tools, right? A mammogram is basically an X-ray of the breast. And so it uses a generator and it uses a detector. And the breast is in between, so it generates images of the breast. What's different about this technology versus a mammogram is that a mammogram is truly a two-dimensional image. It's kind of like a chest X-ray. And so what we're doing with cone beam breast CT is basically a truly three-dimensional CT examination. So instead of going a single plane right through the breast, what we're able to do is go all the way around, because the breast is a three-dimensional organ, just like every other part of the body. And so if we're only seeing it in two dimensions, we're not truly able to identify all of the spatial resolution necessary to find those small cancers that can be missed with traditional mammography. Now, it may be kind of confusing, and so I'll try to explain it to you. One of the things that has come out in the past 10, 15 years is what's called 3D mammogram or tomosynthesis. It's really a misnomer, and it's not actually three dimensionals. It's not actually three-dimensional technology. What it really is an X-ray, which is a single shot, and it spins the detector about 15 or 30 degrees this way and 15 to 30 degrees that way. It doesn't go all the way around. So what we're doing is we're really completing the cycle of going all the way around the breast. So we're improving on the existing technology that already exists out there, which is they call it tomosynthesis. Some people call it 3D mammogram. But as I described, it's not really truly three-dimensional. And what we're doing is we're completing the cycle and making it a true cross-sectional imaging modality that can find those small cancers that can be missed with traditional mammography.
Oh, sorry.
No, go right ahead, Dr. Richardson. I'm interested in your comment as well, please.
Oh, I was going to say the other thing is people have a kind of a keen understanding of MRI, and MRI is an example of true 3D imaging of the breast tissue, where when we look at the summation of all of the information that the MRI collects, we can create essentially a model of the breast and kind of spin it around and see all of the intricacies of the fat lobules and the breast glands, and if there are any masses. Now, I am not a radiologist, I'm just a mere surgeon, but some of the frustrating parts of working with tomosynthesis 3D, this 3D mammogram, which it's not, some of the frustration is when you're seeing the tissue kind of stacked on itself, you can't see through all the tissue. So sometimes you can have what's called summation artifact, where the tissue is just sort of heaped on itself. And from that view, it looks like it might be a solid area or a solid growth. With this true 3D technology, we can see that it's not a solid growth. We can see that it's just tissue that is in that arrangement. And one of the great advantages of this technology over an MRI, which has that 3D, is it's much, much faster. And it has the ability, because it is using X-rays like a mammogram, it has the ability to see some calcium deposit patterns, which the MRI can't see.
Mm. Very, very interesting. Thank you.
One way to think about this is kind of, if we go back to thinking about a chest X-ray, right? If we use the analogy of a chest X-ray are very helpful. We use them all the time in radiology. We look for things like pneumonia, pleural effusions, pneumothorax, heart size, you name it. But it's a truly two-dimensional examination. If we're ever trying to find lung cancer, we're not going to be using a chest X-ray because it just doesn't have that sort of spatial resolution that we need to find those small cancers. And so for lung cancer evaluation, we're always going to use CT. Why? Because it's a truly three-dimensional examination, cross-sectional. We can pan through the images up and down, side to side, front to back, and we can really use triangulation as our friend to evaluate the abnormalities to see, is there any small growth in the lungs or not? So we're just applying the same sort of terminology, the same sort of dynamics to the breast, which really haven't been done before aside from MRI, as you mentioned.
No, that's great, and thank you. So we clearly understand now not only how the technology works, but how we're using that technology to advance early stage breast cancer detection. And I appreciate the fact that we're comparing it in multiple ways to conventional mammography, to MRI, for an example, the ability that we have to use the breast CT with and without contrast when warranted. So this gives us an open opportunity to understand the broader feature sets of breast CT. And I appreciate that. And that brings me to asking you a little bit more about some of your collective experiences, and what clinical applications that you see most promising and most realistic in the near term.
I would love to jump on this if I can. So again, not a radiologist, just a mere surgeon. But one of the things I love about this imaging potential is when I do really lean into the contrasted studies. So for me, for our practice here in Los Angeles, we're an urban practice that skews very young. A lot of our patients are very young. A lot of our patients fit in those high risk categories. They have extremely dense breasts. They're showing high risk scores, high computed risk scores. These are very educated patient population that really knows a lot about their family history and their personal history. They're aware that if they have an elevated risk score, that they need additional advanced imaging and contrast-based imaging. So right now, the basic choices are, for most centers, they're going to recommend an MRI and a mammogram and an ultrasound. Other centers also have a thing called contrast enhanced mammography, which is where we inject a little bit of contrast and then do a regular mammogram. That's also that 2-dimension. We're not getting the same 3-dimensionality. When I get a patient that is a high risk patient and I get a contrasted cone beam breast CT, we like to call it VeraScan at our center. When we get this type of study, I have everything in one step. If that patient has something abnormal, I know the extent of it, I know the position. If we decide to perform a biopsy, I can use the machine to guide a tissue sample to that area very easily. Or we can choose to look around to see, can we identify it with ultrasound? And an ultrasound biopsy can also be performed. If that returns a diagnosis of something I need to take action on as a surgeon, I have everything done. I have in other centers, you have to do several more mammograms. You have to order an MRI. You have to look at to see, well, what's the extent? And then you have to add contrast to the imaging. We've done it all. We can see the extent of disease. It's one single test. And then once the tissue sample's been performed, if we diagnose a cancer, I have everything I need. I don't necessarily need to do anything else as far as imaging is concerned. So it really simplifies the process and streamlines that patient care for me.
Oh, fantastic, and thank you. Dr. Reaven, I'd like to get your comments from a radiologist perspective on image quality and lesion characterization and even workflow. Dr. Richardson did a great job of explaining how she uses it, but if from the radiologist point of view, could you go over what you have learned by utilizing breast CT as it pertains to the imaging process itself?
Yeah, absolutely. Thank you for the opportunity. Up until this time, I've basically read over 1,000 breast CT examinations in the past few years. So I have a lot of experience when it comes to using this technology in a current workflow environment and identifying abnormalities, characterizing lesions, and making diagnoses of breast cancer. And so what I found, and those of us that read these studies, we talk about the literature, we talk about the characteristics, we talk about all these findings. We're able to, anyone we all know what breast cancer looks like with an X-ray modality. We also, as radiologists, know how to navigate a CT examination because as part of our radiology training, we've all read head CTs, chest CTs, abdominal CTs. So if we basically just put the two together, we're able to work through this workflow very quickly, and we're able to find things that we need to find very accurately. So the detection is quite good. I'll talk a little bit about the numbers because in the radiology world, we care a lot about sensitivity of the examination. And so sensitivity, I know a lot of medical people on here understand what sensitivity is, but for those who aren't, basically what it means is if you have 100 women with cancer and you were to scan them with different modalities, how many of those would be positive, right? And obviously you want the higher number, the better. Nothing's 100%. So we have to understand that part first. But if we talk about sensitivity of the examination, when we think about regular traditional mammography, it's probably in like the 75, 80% range, which is pretty good. But I think we would all agree we could do a lot better. There was a meta-analysis done in 2024. And in that study, the sensitivity of mammography was 77%, right in line with what we'd expect. The sensitivity for cone beam breast CT was 92%. So obviously a lot better. We're able to find a lot more cancers that we know are there with this technology compared to traditional mammography. And we have other studies that can corroborate these findings. There was a paper in 2024 which showed that the mammogram sensitivity was 78 to 84%. A non-contrast CT, meaning not even giving contrast, just doing the CT. The cone beam breast CT brought it up to 89%. And then if you add contrast to the CT, then you're able to get the sensitivity up to about 90 to 95%. And so that's right in the range of what breast MRI is able to give us. And so we know that these numbers are out there. We know that we're able to identify these abnormalities better than traditional mammography. And so we're using this technology in daily workflow across the country right now.
Thank you, Dr. Reaven. Yeah, excellent follow through on this as it pertains to the radiological side. Before we go any further, I'd like to welcome Dr. Mark Hiatt to the panel. Thank you for getting in, Dr. Hiatt. I'm glad you got through your little technical spat. So welcome and thank you.
David, it's good to be here, and it illustrates how technology can be limiting. And it's very important as we discuss new technologies for diagnosis that they work.
Yes, exactly.
And I just like to add to Dr. Reaven's excellent exposition about sensitivity by speaking about technology. And here I have something that we used to have prior to the current technology of digital books. And this is Don Quixote. And it kind of illustrates that through traditional means of mammographic acquisition, it was all 2D, right? So the X-ray beam would go through the book, and it's as if you're attempting to read the book, not page by page, but rather from the front cover to the end cover. And so that's kind of the problem of conventional traditional means of diagnosis. What 3D acquisition allows, without reconstruction, but from the very beginning, acquisition, that slice by slice, and so that you can thereby improve your sensitivity as you scan through the breast tissue. And so that's one of the key things that I understand as a radiologist, that it really helps me in having true 3D acquisition, which allows for true 3D visualization.
Very good. I appreciate that. Great analogy. And your timing is perfect, Dr. Hiatt, because several of you at RadSite and other members of the RadSite Quality Control and Guidelines Committee are working diligently to bring guidelines to breast CT and to maintain a high level of quality and safety issues. I'd like to shift the conversation from the clinical and the application side to this side. I think many of the viewers would be very interested to hear, where are we going with guidelines for use, and how is that going to impact quality and safety, of course?
Sure. And but just by way of introduction, I'm a radiologist, but also chief medical officer for RadSite, which is an accreditation body. And we're actively working through our volunteer standards committee to develop standards and guidelines to assure the safe and quality usage of this new modality. Because as cone beam breast CT gains clinical acceptance and adoption, I think it's important that concurrently we develop standards to assure people's confidence in this new technology, not to inhibit it, but rather by making people feel safe about its safety and quality, that they can more freely adopt it.
No, that's excellent. And that work is very much needed. It's the way our radiology industry operates, is under very good quality control and guidelines for use. So I think that we're keeping up with the standard of care in the industry by adding these elements to cone beam breast CT. And I appreciate that side of it very much. I have a couple of questions for the entire panel to please chime in. I think there are very specific cases that each of you have worked with in the past. And of those cases, can you touch on a few things that you find that has improved your ability to understand the condition of the breast tissue and how you perhaps have changed your approach to that patient population? Could I ask Dr. Richardson for you to start first?
Sure, I can think of one specific case where a patient had history of DCIS in one breast, had successful oncoplastic reduction. For those of you who aren't familiar with that, that's where we essentially do a double breast reduction, and in removing the tissue for the breast reduction, we're removing cancerous tissue as well. So the aim is to make everything beautiful and even, and also to rid the patient of cancer and cure their cancer. So we did that successfully on one side, and she came back at her 1-year check to make sure everything was great. And on the opposite breast had a little tiny area of calcium deposits. Calcium deposits and DCIS, which is cancer cell, the condition where the cancer cells are trapped within the milk ducts, that can be notoriously hard to detect. It can be very hard to see, and it can be very hard to see the extent of disease. So with this patient, the equipment was still kind of new in our office. So our radiologists were sort of eager to see, well, what would this look like on the new machine, and can we take a tissue sample of this area? And it turns out we could, and we did. And then on top of that, once we got the diagnosis, unfortunately, of now brand new DCIS on the opposite side, we did not perform the contrast up front, which I usually do, but for the sake of time, we didn't do that for this one patient. So now we have the cancer diagnosis. We did the study again with the contrast. Ideally, we wouldn't do that. Ideally, we do the contrast up front. And what we saw was a very small area of calcium deposits, just a centimeter, like my pinky fingernail. But beyond that was enhancement, extra blood flow all around that area, where the concern was, wow, this could be disease that's far and beyond just the tiny calcium deposit pattern we see. So I talked to the patient about her choices and said, well, we don't really know what this is. So our choices are, we could just remove this area where we know is cancer and see how clear the edges are. We could attempt a lumpectomy. We could take a tissue sample, so direct a biopsy at the far ends of where we see this abnormal blood pattern to see if we could see what the extent is. Or we could, you've had one cancer, this is now another cancer, we could just go forward with mastectomy. So that patient said, you know what, enough is enough. We tried, I don't feel comfortable with keeping my breast tissue, I want a double mastectomy. So we did the double mastectomy, and the imaging had shown that her healthy breast that we had treated with cancer, we said, we don't see anything in that side. The final pathology showed that was accurate. There was no disease in her right breast. We had cured it. And in the left side, everything that we saw with abnormal blood flow, all of that was cancer. So the test was correct, the imaging was accurate, and that saved us from multiple steps, multiple processes. Now, undergoing either of those other options, to try a lumpectomy first or to do a tissue sample to direct to define the extent of disease, both of those things were completely correct and completely reasonable options. But it was such a huge relief to see this amazingly accurate picture of this disease pattern. That and invasive lobular carcinoma is notoriously difficult to find. And I find that with the VeriScan system, with the cone beam breast CT system, it does an amazing job of showing us things that otherwise are almost impossible to see on ultrasound, or a little bit questionable on diagnostic mammography. I'm very impressed with its ability to see the lions, the tigers, and bears, so to speak.
Very good. Thank you so much. Dr. Reaven, as a very experienced reader of cone beam breast CT image data, I'm sure you have a couple of things to share that you think the viewers would enjoy hearing about from the radiology side.
Yeah, absolutely. I mean, I could talk for hours about the small cancers we found, the calcifications we found, all sorts of things. But what I'm going to touch on is something that we may not think about first when we talk about breast CT and its ability in this situation, but and that's breast implants. So there's millions of women in the United States with breast implants, and so a lot of them currently are not going to get mammograms for specific reasons. One of which is they are concerned that the compression associated with traditional mammography may actually rupture their implant or may rupture the capsule around the implant and could potentially cause disfigurement. They spend a lot of money on these implants a lot of times, and they don't want to have a cosmetic malfunction based on the actual test that's going to try to diagnose their breast cancer. And so it's a lot of people that just don't currently get mammography as a result. And those that do, what happens is they come in for their mammogram, the technologist will do the regular views, and then what they'll do is called the implant displaced view, where they literally are pushing the implant back and doing a second set of images. So instead of the traditional 4 images for a regular mammogram, they're now getting 8 images altogether, which is more discomfort, more radiation, more compression, all these other things that people just don't like, more manipulation of the breast. And so a lot of them are avoiding mammography altogether as a result. But again, these women are women who are still getting breast cancers, and we can't just ignore that fact. And we have to find ways to adapt. We have to find tools that can be available to image these women to detect their breast cancers. And so with cone beam breast CT, the advantage here is that there's huge advantages in women with breast implants. Number one, there's no compression whatsoever. So there's no risk of any implant rupture or cosmetic malfunction or abnormality. And we're not doing all those additional images, right? So we're not doing the implant displace fuse. Everything is done in one fell swoop. And the third benefit here is that we're actually able to detect any rupture of the implant itself. We can see the implant extremely well on breast CT, and we can identify implant rupture or integrity on very, very clearly on breast CT. In fact, I've shown a bunch of my colleagues some of the great images that we've done, and a lot of the images we are able to detect and identify are better than the ones that we see in the textbook for breast MRI ruptured implants. There's a sign called the Linguini sign we should talk about all the time in the breast MRI literature. And I have a number of cases that I show my colleagues, and this looks like a better Linguini sign than we're seeing on a breast MRI. So we're able to identify these implant ruptures extremely well in this population. And so for the implant population, it's extremely, the clinical applications are spectacular.
I had a really interesting case of a patient who had several episodes of implant placement and revision and with different doctors. And we work really closely with some amazing plastic surgeons, and they have very specific questions. They want to be able to see, why does this implant look like this? What's going on with the position or the shape change or the scar tissue formation around an implant? They have very specific questions. One of my colleagues had placed implants, and a patient went elsewhere for imaging and was told her implant had ruptured. And this colleague of mine said, there's no way this implant could be ruptured. It's 2 years old and it's a cohesive gel. There is no way this is a ruptured implant. We evaluated this patient with the VeriScan and saw that a previous surgeon had placed a silicone, like internal bra, like a sheet of silicone inside, and not all of it had been removed at a prior surgery. So she had a little bit of this material that was placed in to sort of like hold her implant up, and another center thought this was a new rupture of the current implant, and we were able to show no, this is old material, the implant's perfectly intact. So you're right, the resolution is incredible, and the information you can get about breast implants and for cosmetic surgeons is really huge.
And one other thing I'll add is that with traditional mammography with women with breast implants, we're very rarely able to see next to the implant, behind the implant. We just cannot evaluate that part of the breast. With breast CT, we're seeing all the way back to the chest wall. We're seeing ribs in most cases. Mm-hmm. And so we know for a fact we're not missing anything next to or even behind the implant. These are places that a mammogram is just not going to be able to interrogate at all.
Wow, that's so many fascinating topics to discuss. And I think at this time, I would like to thank the panelists very much for taking part in this very interesting discussion. And perhaps we can open it up to Q&A to the viewers, because I'm sure there's questions out there. So if you don't mind, Andy, can I turn that over to you? And if we've somehow lost Andy in getting to the next step here, we can continue talking about this fascinating topic.
One thing, David, as Andy may be coming on, I just wanted to comment in terms of potential clinical applications.
Please.
Doctors Richardson and Reaven both gave excellent applications, one for problem solving, the other for implant imaging. And I suspect that early on, that those will be the richest applications initially, as opposed to general use screening. Mm-hmm. So I just feel that those may be the best. The near-term role may be best for diagnostic, for problem
Yes.
solving, and not so much for screening. I don't know if my fellow panelists would concur.
Yeah, so at this moment in time, where we are today, the FDA indication is for diagnostic purposes. So we're using it under FDA guidance for diagnostic purposes. So women with breast pain, with palpable abnormalities, implant evaluation, dense breast tissue, family history of breast cancer,
Findings on other
noncompliance.
imaging.
Yeah, non-compliance with traditional mammography. We have all sorts of indications where we currently are using it. We have about 900 patients submitted to the FDA right now, and we're waiting for the screening indication. And so they have all of the information. They have all the statistics. We're waiting on them to evaluate this currently, and we're hopeful that the FDA will weigh in on this quite soon to grant this specific modality the screening indication, which will allow for everyone to be able to use it over the age of 40.
Application. So truly in that pre-FDA approval state, just from a payer perspective, I think it's a lot easier to have focused use cases,
Yes,
with a clear rationale. And that's, much easier to evaluate for payers and for the FDA than, these broad claims of general superiority, which may ultimately be validated. So
Yes.
I think correctly, the potential valuable areas early on would indeed be those such as lesion characterization, problem solving, the aforementioned implant imaging and evaluation, maybe procedural planning in the case of Dr. Richardson. So these are probably the easiest early on uses before we get to the FDA approval. And one of the things I wanted to note from your previous excellent comments, Dr. Reaven, is that you cited in those with implants their reluctance to undergo a procedure through conventional mammography that requires compression. And I think that's true for women in general, whether they have implants or not, just this fear or distaste for the very real unpalatability of having your breast compressed, which is not necessary for cone beam CT. And I just like to cite from my experience as a payer that the compliance to a mammography is not perfect. It's reported that anywhere from 20% to 33% of women nationally do not undergo screening mammography if screening becomes an alternate indication of CBT, just because of the unpalatability of the compression.
Right. Yeah. So what we're looking for is a more compassionate examination, compression-free, pain-free, discomfort-free, and also for a lot of women for whom modesty is important. They don't necessarily want to be touched and pulled and tugged with their breast, even by another woman. So,
I have to just to share, I have had the study. So me personally, I've had the study. It's very quick. It's very easy. And I was also the first biopsy patient at our center as well. So I've actually also had image guiding tissue sampling as well with the device as well. It's very easy. It's very simple. It's kind of astounding how quick it is. So something like an MRI where the whole process is an hour, it takes up all of that time in a schedule. It takes up your staff. This, for me personally, when I did my very first scan, it was a contrasted scan. For me, walking in the room to walking out of the room was 8 minutes and 38 seconds.
Wow.
And that included me getting undressed and dressed. That also included that time as well. So it's very fast. It's very easy on staff. The device itself, has its own housing. There aren't any special room requirements. It's essentially, if I'm not mistaken, it's just like a mammo room. So whatever you would need to set up for a mammo room, it's very, very easy to have in the office.
Great. Thank you. Thank you very much. And panelists, again, thank you. And if we can turn this now on to find out if there's any questions out there, we've got all the right people on the call today.
Yes, I'm so sorry. I was stuck on mute. What kinds of practices or health systems do you think are the best early adopters of breast CBCT?
Oh, I have an idea, but Rich, I'm going to let you go first.
Well, I think that there are a lot of places out there that could benefit from this technology. A lot of health systems have issues with their compliance rates when it comes to women who are getting screened or women who are getting imaged for their breast health. And I think that any of those places, any of those hospitals or health systems could benefit from this. I think there's a lot of women out there who, have implants who this could really benefit from that population. And honestly, most hospitals probably have some use for this because they're seeing a lot of their women not coming in for their traditional mammograms, and they're looking for ways to increase compliance. And this can really help with pretty much every imaging center and hospital across the country.
I think it can really speed up workflow and detection because it's going to cut down on, taking 13 pictures of a diagnostic mammogram. It's a less than 10-minute scan. You're going to get all of it in one scan, and you're not going to need a diagnostic mammogram to look. I think any center would benefit from this, but what I think is super intriguing is the research potential. So what I would really love to see is academic centers take on this equipment because it's so fascinating. We haven't had really new technology for decades now. Now we finally have something that truly sees the tissue in a brand new way, and just the potential for academic exercise and study to see, well, what are the amazing things that this could do that other imaging devices can't? Where does this succeed? Where does it still maybe have some weak spots where we still should lean into maybe other modalities? But I think there's so much potential to learn from this. And I've been really amazed on how it's exceeding my expectations.
And I think, David, to Dr. Richardson's point, that academic focus is really needed in the research to further validate the technology, because payers and the FDA and other groups will be concerned about the clear validation of the ultimate outcomes that optimistically we envision. Right. And I think that the centers, that will be, although it may benefit all centers, as Dr. Richardson said, I think that the early adopters will likely be, centers with strong breast imaging expertise already, like perhaps at Dr. Richardson's practice, those with disciplined protocols, and to Dr. Reaven's point, with patient populations where the modality really addresses, at least initially, a defined unmet need. And we've given a couple of cases of those, for diagnosis or problem solving, for implant evaluation, and there are yet other such use cases.
Yes, many. And the effort that is being put into the marketplace right now through the Koning Corporation is truly focused on that next phase of adoption, which includes the academic centers that have interest in doing research and to continue to validate that there are improvements in utilizing cone beam breast CT by comparison to the current standard of care. So I think there's a lot of runway here for others that are in the early stage breast cancer detection business and treatment business to understand and to discover the value of this technology. And we are looking so forward to that expanding and doing a great job of it right now and introducing this to those particular centers that you mentioned, Dr. Hiatt. So thank you for that. Any other questions, Andy?
Yes, we do have a couple more. Is there a big learning curve for the RADs to learn to read breast CT?
Yeah, it's a great question. And one thing I said earlier was that as breast imaging radiologists, like we all basically know what a breast cancer looks like. And we know what benign breast disease looks like, fibroadenomas, fat necrosis, on traditional mammography. And we all, as radiologists, know how to navigate through a CT. So if you kind of put those two skill sets together, it takes maybe about 40 to 50 cases to kind of get up to speed, I would say. But once you're past that initial hump of getting the learning curve ready, it's pretty smooth sailing after that.
I have to throw in there again, not a radiologist, but I routinely look at all of my patient scans, and then I'm very heavily invested in ultrasound, so I'm doing ultrasounds on all my patients. So I have been so amazed at just my ability to just look at it all by myself without any input of anybody, and appreciating just as a mere surgeon, about 90% of the significant findings I'm just recognizing because it's so easy. It's just everything, it's so obvious. And then going back through with ultrasound and kind of trying to troubleshoot areas to try to help out my radiologists that are ultimately going to be the ones reading it and generating the report and saying, hey, I recognize this area, this area, this area, and I captured this on ultrasound. I either found a correlate or I didn't find a correlate. What do you think? And I'm about 90% of the time, I'm hitting the things that they would hit. And it's just, I find it incredibly helpful. It's just very intuitive. It's very easy to look at.
Excellent. Thank you.
And another question, with breast implants, is breast CT able to adequately visualize all types of implants, or does it perform better with certain implant types, such as silicone versus saline?
Yeah,
All types.
all types. Yeah,
Yeah.
all types.
And do you think breast CT will eventually have compliance regulations similar to mammography, or will it be regulated differently?
That's a great question. I mean, David, do you want to weigh on this? I
Sure.
think that there may be some potential applications for compliance, just like MQSA does for mammography. But we're kind of a long ways off from there. But I think it's a good idea.
We promote the fact that we should be involved in programs like that because it's what the industry is expecting. It's a bit of a safety valve, and we would promote that. And it doesn't matter to us whether it's MQSA or some other opportunity. And by the way, we initiated this form of either quality control or understanding of how the practices were integrating this by way of the accreditation process that is available through RadSite. And that gives us a good foundation to understand just what do we know about breast CT in each of these facilities and how well are they performing the exams. So we're very, very grateful for the amount of time and energy that was put into the RadSite accreditation program for cone beam breast CT. And we think that that will be very substantial in how other centers are going to find that comparison, if you will, and have something to compare against and understand where they are within that quality realm. So to us, we're rather agnostic about whether it's MQSA or some other entity that wants to do it, but we certainly have proven, and Dr. Reaven, your center was the first one to be accredited through the RadSite process. And I think you found that to be appropriate and very thorough. So if you have any comments on that, I'm sure the viewers would love to hear.
Yeah, well, first of all, I want to just thank RadSite for the opportunity for promoting the accreditation for cone beam breast CT because we were the first, as you mentioned, location. I'm working with a location in Dallas called the Painless Mammogram. And we were the first location in the country, in the world, to have this specific accreditation for this modality. And there have been a bunch of others since. And so we're really thankful that this process is moving forward because, as we all know, accreditation in the radiology space is very important when it comes to a quality check on what we're doing and making sure that everything's done properly, the images are obtained properly, the radiation levels are appropriate. All these things that we talk about are basically housed in the quality of RadSite. And so we're very thankful for that opportunity. And I think that as moving forward, there'll be a lot more places looking to get accreditation for dedicated breast CT. And we look forward to those conversations.
Absolutely.
Are the technologists performing the scans mammographers or CT technologists?
It's a great question, and some of it varies by state. What I will say is that it can either be mammography technologists or CT technologists. There are some states, such as California, and Dr. Richardson can talk about this, that require a specific type of technologist. Like in California, they require mammography technologists. But in other places, it can be a CT technologist, it can be a mammography technologist. In some places, it can even be an X-ray technologist. Heather, do you want to go further on that?
Right. The state of California requires it to be somebody who is specifically trained in handling radiologic breast imaging, so a mammographer. But honestly, it's so easy. It's so easy for our techs. There's really not much to do. It's just making sure that all the settings are correct, that everything is done safely. But there's not a lot of positioning. There's not a lot of there's not a lot of specifics that needs to be done for the test. It's basically just making sure that the images are procured and sent to the PACS system correctly. It's really more image handling and from the computering side of it rather than the patient side of it. And then of course we do utilize contrast, so we do have to have a MD present for the contrast, and then we have to have a staff member who can put in the IV. And dealing with issues, we're always ready for contrast. We're very much educated on contrast reactions and you know, everything that you have to do to be up to date on that. But if you're not using contrast, infinitely easier as well.
And is the accreditation process requirements different for DBCT compared to traditional CT, as an example? And if so, how?
Well, we're in the committee, we're formulating those standards, and we have a new version forthcoming in which we certainly make our standards with respect to the technology, the policies, and the staff, the personnel, all, you know, specific, of course, to the body area being imaged. And that's done, you know, throughout RadSite's programs.
I think right now, I mean, for us, we were the first in California, the first unit in California, and I think that the 8th in the country. And David can correct me on that if I'm wrong. But since it was so new, it was just uncharted territory. It was essentially sort of given the under the auspices of standard CT, and we kind of had to figure it out as we went along. So I personally am a little jealous now that we have RadSite that can guide us through the process probably a lot more easily and directly going forward. So that should be great.
Right.
And what new guidelines have been established?
We're actually finalizing a set of guidelines that should be coming out pretty soon, right, Mark and David?
That's right.
That's right.
So, you know, as David and Dr. Reaven know, we have a committee comprised of, you know, dozens of experts from across the country, you know, cross-sectional. We have, you know, radiologists, you know, the end users of these diagnostic technologies, such as Dr. Richardson, you know, surgeons, we have technologists, and essentially, you know, developing these standards to assure consistency with respect to safety and quality. And really the objective is to give confidence when we have this novel technology such that regulators, payers, providers, health systems can feel confidence that there is that assurance that the technology is used consistently and safely.
And similar to MQSA guidelines, we absolutely include the medical physicist into our decision making because they have such a unique view of what's going on in this X-ray emitting device. So the physicists that are on our committee are very valuable in making sure that our safety and our quality standards are consistent from site to site and within the guidelines that we're creating. So very happy to have that cross. And we did that in digital breast tomosynthesis when it was released. There was training for the radiologist, there was training for the physicist, and that gave us some consistency across the annual checks. And we expect to do the exact same thing with breast CT.
Yeah, so be on the lookout pretty soon for the guidelines, which will be released by RadSite pretty soon.
Yep, great. And
I have one more question. Looking ahead 3 to 5 years, what role do you think breast CBCT could realistically play in breast imaging?
I think it's going to give.
I'm going to turn that over to the radiologist and surgeons.
I think it's going to give MRI a run for its money. I think that there's going to be it's so much faster. It's so much easier for patients. It's you know, there's MRI can have some flow curves and has slightly different imaging, but at the root of it, the ability to appreciate an enhancing lesion and define in 3-dimensional space where the abnormal tissue is, I think it's fairly equivalent to MRI. I'm really looking forward to seeing more data about the advantages of being able to see calcium deposit patterns as well, which MRI can't do, to see how much that folds into helping define disease. But I really think it's going to give MRI a run for its money, considering it's so much easier to have in a center and it's so much faster. I think I really do think that we're gonna see a shift of seeing that there's an equivalence of MRI in a lot of ways, and people leaning into this in the future over MRI.
Mm.
Well, I agree with Dr. Richardson that it'll give MRI a run for its money, and for that matter, all competing modalities. I think there'll be an increase of cone beam CT vis-a-vis these other modalities that are used in, breast delineation and diagnosis. I would say, though, with the one limitation that I don't foresee in the next 3 to 5 years any wholesale replacement
No.
of any of these conventional modalities. Rather, I
Right.
see over the next several years, and I think my co-panelists would agree, more of a realistic path that is an evidence-supported role in selected clinical applications, as we've discussed, rather than that wholesale replacement, at least in the next 3 to 5 years.
Right.
Yeah, I agree. And I think that, with a lot of people now talking about dense breast tissue, the importance of dense breast tissue, and why mammography is suboptimal when it comes to dense breast tissue, people are looking at other modalities. There's a lot of people looking at ultrasound, people looking at breast MRI, people looking at contrast-enhanced mammography. And I think that once they see that there's even another competitor to this modality when it comes to ability to detect breast cancer, and they can see the potential of breast CT, I think places that are groundbreaking, places that want to be on the cutting edge, are going to want to experiment with using this in their clinical workflow. And those that do, I think, will find it to be very successful. The patients are absolutely going to find it very helpful, very comfortable, very compassionate. And these are things that the early adopters and the people on the cutting edge are going to really see from not only their clinical applications, but also their patient population that's requesting something else.
Right.
Yeah, we have a significant number of patients that are seeking it out and contacting our center because they're researching what's an alternative to mammography. They don't want a standard mammogram.
Yeah, so it's going to be not only radiologist driven, surgeon driven, oncologist driven, gynecologist driven. It's also going to be patient driven. And I think that's one thing that people are going to start paying a lot more attention to is what are the patients requesting? And are they requesting an alternative that doesn't require compression, that doesn't require the pulling and the tugging, the squeezing, that's much more comfortable for them.
And fast. It's
And
very
fast.
fast.
7 seconds.
Well, I love that. It's true that having been in the machine, it is 7 seconds, but there's a little bit of a warm up of the machine. So it's technically, you have to lie there for 10. It's not over until 10, but yes, it is 7 seconds. But for those of us who are counting, it's more like 10, but it's so fast. It's so fast. 10 seconds is nothing.
Excellent. Was that the last question, Andy?
Yes, that was the last question.
Great. So, Dr. Hiatt, would you like to close this out for us, please?
Sure. I'd just like to thank you, David, for doing such a great job in moderating, and from my co-panelists, Drs. Richardson and Reaven, just from your vast knowledge and experience with this novel technology. And I'm hopeful that this will be a benefit to patients across the country. I'm also grateful to RadSite for hosting this webinar and also for developing the mentioned standards to assure that there's confidence with how this new technology is implemented and used. Excellent. And as you can see here on the screen, that if there's any need to contact RadSite about the standards that Dr. Reaven mentioned that are forthcoming, you can do so in any number of these means by going to the website, by calling, by emailing. And again, thank you all also for your attendance and interest in this very timely and potentially impactful issue.
And RadSite would like to thank our moderator, David Georges, and our panelists, Dr. Mark Hiatt, Dr. Richard Reaven, and Dr. Heather Richardson. Just a reminder that today's webinar has been recorded. Please visit our webinar page on RadSite's website at www.radsitequality.com or our YouTube channel for this webinar recording and past webinar recordings. If you would like to learn more about RadSite's accreditation programs, contact us at info@radsitequality.com. And thank you again for joining us today. We look forward to seeing you at future webinars.